maintain a healthy diet, because so much of our diet depends on smell. Like if I smell something nicer, I am going to go and eat that. So that affects their healthy diet and nutrition as well. Now, speech and swallowing are affected. Dysphagia, they could have difficulty swallowing. Their speech, now think about this, everything is slow and everything is small. So slow and small basically is the problem with Parkinson's. So speech also is going to be lower in volume. It's going to be slow, and then the tone of the voice is going to be just monotonous. Patient cannot go up the tone or lower the tone. It's just going to be the same tone, and then difficulty with articulation as well. Now keep in mind hypokinesia and hypokinetic speech. So we talk about this when we talk about LSVT. Patient could have difficulty with autonomic nervous system as well, excessive sweating, excessive oil secretion from their skin, and also constipation. Cardiopulmonary function can be affected because of rigidity. There is going to be less chest expansion, so less vital capacity, reduced chest expansion. Also, heart is affected. They could have diminished heart function. Heart is not functioning that great. So, orthostatic hypotension as well. And also, when you make the exercise, they are going to get tired pretty soon because their heart is not up to a normal, healthy level. Gait is one of the, I would say, important feature because, without gait, without walking, you cannot be independent. So, we'll discuss gait in a little more detail, so I have a separate slide for that. First of all, in the initial stages of the disease, people could begin with reduced arm swinging. It could be asymmetrical arm swing reduction, maybe right side less arm swing, left side less arm swing, and then maybe no arm swings for both. It depends. And then patient could have small rapid steps. That's called as shuffling, small rapid steps. And I will show you how that happens. Then fascinating gait, because of the small steps and forward posture, patient is just trying to catch up with that, and it starts walking faster. So that's called as fascinating gait. Difficulty with turning around, and freezing of gait, it is really debilitating. So in freezes, especially when there are narrow doorways, and if they go to public places and it's a lot of people around, they are going to freeze. And as the disease progresses, freezing is going to become more common. So I have the video, and I'm just going to go out of this and show you just some of the freezing episodes for Parkinson's disease. Can you all still see my screen? Dr. Himanshu, can you all see me? Okay. Can you all see the video? So these are oh, okay. Okay. Oh, I think I have to go, and then I possibly have to select that I want to show this, right? Yes, yes, yes. Yes, yes, I will do that. I think now you should be able to. Now can you? Yeah, okay. So these are some of the cases, and you can see their gait. There's reduced arm swinging. You can see one arm is stiff. Here also you can see that the patient is keeping his left arm is not swinging that much. This is what you can see in mild to moderate Parkinson's. There's shuffling steps, stooped posture, increased cadence. In advanced stage, reduced step length. Difficulty turning, they're taking so many steps to turn. Okay. So we go back. So these were just some examples how patient could present. Can you see my PowerPoint now back again? Okay. Okay. So let's talk just in brief about the pharmacological management, because with pharmacology, it is kind of important with Parkinson's disease, because they are on drugs which basically either replace dopamine, which is lost, or they try to help dopamine, which is whichever amount is now left, they just try to help with the function of whatever is left. So most common is dopamine replacement. That's levodopa, carbidopa. That's the gold standard. And the thing with levodopa, carbidopa is that after 4 to 6 years, the benefit would start to go off. Then you have to either, try some more dose or change medication. I mean, there are the benefits will start to go off. And one more thing about levodopa and carbidopa is that whenever the drug is effective, that's called as on phase. So suppose I took the medicine right now. The medicine will be effective for a few hours. That time I will be at my highest level of function. Then when the effect of that drug starts to wear off, then the symptoms are going to come back again. So when patient comes to your clinic, you have to make sure that you have seen the patient at both times. You have seen them in on phase, when their medication was on, they were at their highest level of function, and also when they were not on medication, so that you know that what are the different things that can affect them when they do not have the medication on, and how it can affect their function. So this is about dopamine, and other drugs are dopamine agonists and some anticholinergic for tremors and dystonia. So all the symptoms we discussed, they will be in their worst shape when the patient is in off cycle of the medication. So let's talk about the assessment. What would you do in a clinic? So I'm talking here about what we have usually seen and done. You would look for rigidity, you would look for tremors. Look at the left side of the column. You would look at rigidity, you would look at tremors, you're doing bradykinesia, you're looking at this slowness of movement, you're looking at their strength, you will find their balance. You will look for coordination, their flexibility, the tightness of muscles, range of motion, and you would also look for gait. So yes, this is what we do, but so my suggestion here is that along with these assessments, you are doing that assessment, but try to be as objective and specific as possible. So try to have some numbers associated with that. How can you have numbers associated with that? So on the right side of the column, here are the different outcome measures, or you could say scales that we use to monitor their progress. Because we need to have some numbers. How would you, like say the tremors, how would you define how much it is? You need to have some numbers so that you can monitor the progression of the disease. So here are these outcome measures on the right column, which are recommended by American Physical Therapy Association. So this is what they do here. Unified Parkinson's Disease Rating Scale for their body structure and function. and also Montreal Cognitive Assessment Scale. This is for cognition. For their activity, you could do a 6-minute walk test, which is going to assess their endurance, and you could do a 10-meter walk test for gait speed stride cadence. You could do a best test. This is for posture and balance. Then you could do a functional gait assessment for their gait, 5 times sit to stand for their balance as well as for lower extremity strength. And we will be talking about these. And for their participation, you could use these two different scales. One is the Parkinson's disease questionnaire. This is for quality of life, and it is very specific to Parkinson's patients. You could also use freezing of gait questionnaire because they will have freezing of gait, so you could use that questionnaire. Both of these scales, Parkinson's disease questionnaire and freezing of gait, they both are self-administered. So you don't have to do anything. You give them the paper and they are going to note down whatever they feel about their symptoms. So now if you look at the left side of the column, you can see that these are the different symptoms you have and the different things that you are assessing. Now look at the right side. This is going to give you an objective measure of whatever you were trying to assess. Yes, for some things, definitely, you just cannot, we do not have scales or outcome, we do not have outcome measures like coordination and stuff. You are definitely going to take them to, finger to nose tests and stuff. But these on the right side are going to give you an objective measure. And why are they important for you to have at least one or two? You don't have to do all. I know that we are all busy. We have so many patients. You do not have to do all of these outcome measures. Suppose patient has more balance issues, then you are just going to do best test. That's for posture and balance. Suppose patient has a lot of issues with gait, you would probably be doing functional gait assessment. If you're really working on 5 times sit to stand, you're going to do lower extremity strength, you could do 5 times sit to stand. If endurance is the problem, you're doing 6-minute walk test. So this is going to give you a number and you can monitor the progress of the disease and how well the patient is doing. Let us look at some of the examples. This is a unified Parkinson's disease rating questionnaire, and it has questions about all of these things. So these are just questions about all of these things, and patient is going to rate, or you are going to rate. So half section is rated by patient and half is done by you. So you're going to rate from 0 to 4 all of the questions related to these categories, like activities of daily living, balance, behavior, cognition, communication, coordination, dysarthria, sleep, swallowing, pain, participation, quality of life, and depression. So you are just rating questions related to all of these categories from 0 to 4. So 0 means no problem and 4 means severe problem. So the lower the patient scores in this questionnaire, better it is. The better the patient is doing. Okay. This is the Montreal Cognitive Assessment, and why I'm talking about these scales, because these are specific, and also all of these scales and outcome measures, they have been validated in patients with Parkinson's disease. So this is about the cognitive assessment. Here they have different questions like memory. You tell the patient to read a list of words, then tell them to recall after 5 minutes. There are things for attention, language, orientation, then delayed recall. So you could just use this and figure out their cognition. Because if they're not doing good with your physical therapy, then there's something you need to track. Maybe their cognition is going down, something is happening. So that will help you track what's going on. Himanshu, anything? I need to change my volume or whatever. Okay. 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 Thank you. Okay. Just a second. My slide, I think, froze. Okay. Here I am. Okay. So this is the 10-meter walk test. This is to assess the gait, mobility, and their walking speed. Now look at this test. Just look at this figure here. And in the figure, you can see what they are doing. So the patient is going to start maybe at this place where the arrow begins on the left side, this place. And the patient will start to walk. The patient is walking and you will start your timer at where it says start timing. So you give patient some warm up. You tell the patient to walk, but don't start your timer. What are you doing here is it's a 10-minute walk test. You tell the patient to walk, 10-meter walk test, I'm sorry. So you tell the patient to walk for 10 meters and you measure the time they take to walk 10 meters. So you tell them to walk, you start your timer when they are here at this point, start timing. And then when they are done with 10 meters, you stop your timer. And then they can slow down. Don't tell them to slow down. You just stop your timer. They will just walk a little bit more and then they will slow down. And then you take 10 meters and divide by the time they took to walk that 10 meters. That is going to be your gait speed. So why is that important? Why do you even need to know 10-meter walk test and what was their gait speed? So gait speed has been related with how much independent they can be in different researches. So suppose if you're working with your patient and he was a very slow walker, he had very less gait speed, you're treating your Parkinson's disease patient, and after 3 months or something, you measure the 10-meter walk test again, and you see that there is an increase in his gait speed. And when you see that there is an increased gait speed, if it is more than 0.18 meters per second, that means you have actually made a difference. So if there is an increase with that much meters per second, your treatment therapy is working. And when you do the test the first time, you can see here that patients who have less gait speed, like zero is like nothing, they're not walking, maybe like 0.2 meters per second or 0.4 meters per second, then they are just household walkers. These are the different research which have been done, and they have shown a proof of, what can you get out of 10-meter walk test. So they are all household walkers. They are less than 0.4 meters per second. They are not safe to go out. They will have falls. If you look at the second black thing, it says risk of death, hospitalization, and fall. So there could be falls. Their risk of falling. Now you go down to the right side and you see the patient has speed of 1.2 or 1.4. That means they can walk well. They can go out and they can cross the street safely. They can do groceries. They can go out, do shopping, and they will be fine. So this is what you are getting. If this speed is really less than 0.4, their risk of falling. Now you need to make sure that at home also their environment is safe enough and they are not falling. And what else can you do? Do you want to give them some assistive devices? Do you want to, alert their family members that they are at risk of fall? And if they fall, they can fracture their hip or something like that. Most common is fracture of hip for Parkinson's disease. And then again, they are going to be in bed more. So you don't want that. So this is what it could be helpful for Parkinson's disease. Now this is the other one. This is 5 times sit to stand. So as the name says, it is 5 times sit to stand. So the patient has to sit, stand for 5 times. and the arms have to be across the chest from the chair. So patient is sitting on a chair, arm across, 5 times sit to stand, 5 times sitting, 5 times standing. How much time it takes? These tests or outcome measures are so simple that you just basically do not even need anything. You just need a timer, you need a pen, you need a chair. That's it. And you just tell the patient to sit up, sit down 5 times, and you note down the time. Okay, how will you now relate? So these are all already studied. So they have already given you the normal values for 5 times sit to stand in a healthy older adult. It is 12 seconds. So within 12 seconds, an healthy older adult above 65 years should be able to sit and stand 5 times in 12 seconds. Now, if the Parkinson's disease patient takes more than 16 seconds, then again, he or she is at risk of falls. And 70% of Parkinson's disease patients, they fall within the last year if you take their history. So it's pretty significant. And falls, if they fall one time, they will restrict their activity, they will be on bed more, they will be less functioning, their health is going to deteriorate even more. So you want to avoid as many falls as possible. So we saw semi-walk test, we saw 5 times sit to stand. Here, this is a very interesting one. This is 9 up and go. And I want to discuss here why it is important for Parkinson's disease, because this test is going to assess mobility, balance, locomotor function, all of that. So what you do here is, it's timed up and go. So as the name says, go by the name, timed up and go. So patient is going to stand up from the chair, walk, take a turn, go back and sit down in the chair. This is the time that you are going to note. So you make the patient sit in the chair, note down your time, start the timer, tell the patient, get up, walk around 3 meters, and then come back and sit. So you have explained everything. You tell the patient, okay, now you need to do this. Patient will get up, walk, come back, sit back. You stop your timer. So also the normal values for these have already been figured out. So Parkinson's disease, if it takes greater than 11 seconds, they are at risk of fall. Now, look at this very interesting test outcome measure. So when you tell the patient, you can assess so many things just by this simple test. So you tell the patient to get up, you can see, do they have start hesitancy? Do they have difficulty starting? It's like getting up. And how well their lower extremity strength is, because they're getting up. How do they have, even you can see the tightness and they will get up in the lower extremity. So you saw all of that. Then while they're walking, you can see their gait. You can look at the freezing of gait episodes if they have any, their stride length, gait speed, you can assess anything. And then also they're turning. So you see what do they do while they're turning. So their turning is bad. You can assess that also with just a simple test, which takes like 5 minutes. You can just assess so many things for the baseline value and then keep working on the patient and maybe assess after 3 months again to see how he or she is doing. Again, we have normal values for those that we discussed. And also along while you're doing this time up and go, you could also do a dual task. That means another task while they're walking in time that up and go test. So you can tell them to count maybe three backwards from starting from 100 or something, or maybe tell them to name all the states that start with A, something like that, and then again note down how much time they took to finish that timed up and go. So there are values again for those. If the task is simple, cognitive task is simple, they might take again 16 seconds. More than that is risk of fall. If you give them tough cognitive tasks, they might take 20 seconds. So this was about assessment. These are the different simple techniques that you could very well incorporate up with your treatment and assessment. So here now we'll talk about the treatment techniques. There are different treatment techniques we have kind of done and we do with our Parkinson's patients. And you know, you guys also in India do it really well, all of this. So I just listed down, but we will talk more about LSVT big. But here is what we all do, right? We all do. You do too, and I do as well. So relaxation, yes, it is important because you are working on rigidity. So that would help with rigidity, relaxation exercises, and range of motion exercises for, you know, they will have tightness of flexors. So range of motion exercises for that, then stretching to all the tight muscles. You could do resistance exercises and you could do it different ways. You could use ball, you could use band, anything you could do. Bed mobility, you could work on their turning, getting up from the bed, sitting, sit to stand, standing, you could work on that. Then balance, there's so many ways to work on balance. You could have a ball, you could have a disc, you could do one leg stance, anything. There's a lot of exercises that you could do with balance. Then aerobic exercises, because their aerobic capacity definitely is going to go down because of their reduced pulmonary function. Then breathing exercises improve chest wall mobility. So we do all of this in our clinic, right? So the only thing here is that while you are treating these patients, you have to make sure that try as much as you can, try that you include functional exercises and task-specific exercises as possible. So do not just work on, you know, maybe you're working on strength. Maybe patient has lower extremity strength issues. You are doing strengthening exercises of lower extremity, making the patient lay down, giving weights, doing all of that strengthening. But if you will go more functional, that's going to really be helpful and patient is going to recover faster. So, and also as task specific as possible. I'll give you one example so that it makes sense to you. So if patient says that patient has problem getting up from the chair. So I would say you ask all the details, how high is the chair and how well are you trying to get up, does the chair have arms or whatever, take all the details and give the patient the same environment where he or she can practice in your clinic. So don't just try to work on strength or lower extremity and assume that those changes, those changes will translate, but those changes might not fully translate to, you know, sit up and standing. So take the same chair or, you know, get the same type of chair in your clinic if you have. Practice in the same environment. This be very, very task specific and very functional. Then you will get a lot of improvement in their scores and everything. So gait training, one of the very useful one is giving auditory and visual cues to them because they freeze, especially when they're walking along the doorways and stuff. So they are going to get frozen. So give visual and auditory cues, and there are different ways how you can give that. Initially give that, but then gradually you have to take out those cues because otherwise patient won't be able to walk. So here is just a little example how you can use those visual and auditory cues. Okay, Manshu, can you see that video? Okay. Yeah, this video does not have the audio. It is without audio. Okay. So this is the time when patient did not had their medication. So look at how much difficulty patient has while turning. They're taking small steps, hard to turn. Difficulty walking. When it is doorway, they are going to take even more time. Look how slow they are, such small steps. The video is just taking 1 minute. Difficulty again turning. Now you put these tapes on the floor. Just look at those blue tapes on the floor and tell the patient to keep the stride according to those tapes. So can you see that improvement? And here, this is the on phase of the medication, and see they're already better because of the medication. And when you give them visual cues at this point, they're going to be even more better. And then gradually move those visual cues as well as auditory cues. I don't know, Dr. Himam was right. I didn't have the audio, somehow I did not play. But for the rhythmic cues, what you can do is you can have a metronome and play that metronome, like tick, 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 tick. And with each tick, tick, they are going to take a step. Then they will not freeze. Okay, so all of the exercises we do, and now I'm going to talk about the LSVT big. They are all based on the similar principles. So intensity has to be high. And don't assume that these patients cannot work. They can. So they need to have high intensity exercises according to their level. So don't, like, I don't mean that, just burn them off by making them do like too much, but have like a higher intensity than they can tolerate. Bigger amplitude, so bigger movements, because you see that they think that they can do everything smaller. Small movements, voice is smaller, their movements are smaller. So everything gets smaller. So we are not doing small anymore. For the treatment, we have to do big. So all amplitude, higher amplitude movement, so that they learn that doing small is not good. It's not right. Doing bigger is right. Then they will come to a normal position, which normal people do. So bigger amplitude, you can increase the repetitions, increase resistance, try to improve their accuracy. Then gradually give them complex tasks and then repeat, repeat, and repeat. You have to repeat many times. And when they do good, give them reward. And be specific. As I said, be specific. Like on the left, you see this is not going to help with the sit to stand. So if you're working on sit to stand, you have to work on sit to stand. Now we talk about LSVT big, and there were a lot of questions and curiosity about that. So here we are. This is the treatment. The full form is Lee Silverman voice training. So it's same voice, but they have two different protocols. One is voice and one is movement. So we'll talk about both. This is Lee Silverman voice training. Lee Silverman was one of the patients who had Parkinson's disease. And they tried the treatment on her, and that's how it is named Lee Silverman voice training. So what is this therapy? This is basically for Parkinson's patients to maintain their highest level of function with communication, their voice, as well as their mobility, and making them as independent as possible. So there are two different protocols for this. One is LSVT loud, that is for speech therapy. To people who work on their voice training and stuff. So that is for speech therapists. It started with speech and then it went to movement. That's how it started. And then it is LSVT big. This is for physiotherapists as well as for occupational therapists. So with this, it has to be delivered by a certified therapist or an occupational therapist. Therapist who is certified with that. Otherwise, you cannot give LSVT big therapy if you're not certified. So let's look at the LSVT loud. Let's look at the example. This is about voice. So they work on their voice and they tell them to speak more louder, and they do training first with words, then phrases, sentences, and then paragraphs. So this was one of the lady, 59-year-old, and after a month of LSVT loud therapy, this was before the treatment. So there's no voice. Yes. Okay, Manju, what do I press here? Yes. Why it's not showing the voice? Hmm? Oh. Okay. Oh, I probably did not. Okay. Yeah, I do not have I do not have on mobile. Here it's not saying anything about voice. Okay. Yeah, because I paused it because there was no voice. Yeah, just give me 1 second. And we can always come back to that video. We can see the other ones which do not need voice. Just give me 1 second. Yeah, because it doesn't say anything here. Okay, maybe we can watch the next one. It does not anyways have the voice, so we'll watch that one. Okay, so we can come back to LSVT loud later, and this is LSVT big. So this one is, again, this one is intensive. You have to be intensive to do all the brain changes. Then it is already evidence-based, it is researched, and they have tested on a lot of patients to figure out its efficiency. It is large amplitude because amplitude is lower, because movements are slower with these patients. So it's large amplitude and multiple repetitions. Repeat number of times, and then whole body movement, because see, rigidity is everywhere, small movements everywhere. It's not just one arm which is affected or one leg which is affected. So pretty much the whole body is affected. So whole body movement, and it is very standardized. So you have to follow this protocol 4 consecutive days per week for 4 weeks. So 16 sessions in a month. It is like a 1 month therapy. So you give 1 month, then you can check how your patient is doing, all the assessments, and you can again follow them up when they start to deteriorate. This is progressive disease, right? I mean, you have to keep on doing something. It's not like you give one them and they'll be better. forever. So you have to call them back again for like 6 months or any year whenever they want to repeat this. And you do again 16 sessions per month, and each session is going to be 60 minutes. So, and they have researched for 25 years, basically. So let's see, this is another case study about a 71-year-old who was diagnosed with Parkinson's. And the reason was that he had slowness, difficulty walking, and history of falls and freezing. They gave 1 month intensive therapy, and you can see the changes here. So you can see on the left side, this is before the treatment, and you can see the difference after the treatment. He's not even using his cane. He seems to be a little independent than before. So this is before on the left side, and this is after. He's going to his car. Look at his movements. Look at his stride length. It's bigger. He has more arms going now as well. So when they did the therapy on this patient, this is what they found, that before treatment he used to fall like 1 to 2 times per month. He used cane, as you saw in the video. Gait velocity was 0.35, endurance was 370 feet, and he could only match to 29% of people of his age. Now, after the treatment, he recorded no falls, no assistive devices. You saw that in the video. Then gait velocity was higher, endurance was higher, and he could match to 100% of his healthy control of the same age. So what they say is that you have to have the Amplitude. It has to be delivered by certification, because they have a lot of different things that you need to take care of. So you have to kind of go over different things with them. And then it is a one-on-one intervention. Basically, you cannot have a group session. It is a one-on-one intervention, and you basically teach the patient that you do bigger movements. Bigger is better, because when they do bigger, then they will come to a normal pace, like a normal people. So this is how the session looks like. It has maximal daily exercises, and I just listed 4. There are like 7 types of daily exercises that the patient needs to do. So it's a 1-hour treatment session. So sometimes they put on these daily exercises, which they are going to do daily anyways. Then, as I said, you have to be functional and specific with all the therapies. The same applies here. They work on what the patient has difficulty with, any of the function that patient has difficulty with. So you can work on sit to stand, maybe rolling, whatever. So sometimes goes for that. And then there are some hierarchy exercises that you need to do that the patient, for example, patient likes to, you have to always ask patient, what does he want from you? So if he says that he wants to play golf, he wants to get in and out of the car, well, you work on that with the patient. So this is going to be specific to what patient is going to say. So you divide your time accordingly, and then there is a homework that needs to be given to them, and they do that homework for full 30 days. So we can practice this one. This is just, I'm just going to share a few different types of exercises about this. So these are the maximal daily exercises. This is forward step, and I'm just going to I minimize this so that I can see you guys. Okay, most of your videos are off, but wherever you are, I would suggest you to just get up a little bit. Get up and we'll just do this one together. Okay, so this is one of the exercises which is called as forward step. So see here what she does, and then I am also getting up. Wherever you are, please get up. So you take a step forward. Take a step forward and back. Take a step forward. Hope you're all doing it. You'll get a good idea what it is. Take a step, stretch your arms, and then go back. Take a step forward, and then go back. So when you do this, you kind of realize that you're opening up your arms and then coming back. So it is stretching as well as you're learning how to take a forward step. So this is one of their daily exercise that patients should do. And this other one, this is side reach. To do this, take a big step and then come back. Take a big step and then come back. Did you all get that? Are you practicing with me? Okay, or nobody wants to get up today. Okay. No, that's fine. Okay, let's do this one. This is rock and reach, forward, backward. So take a step and then just rock, reach, as she's doing, rock, reach. And then now add arms, rock, reach, and then add arms. Rock, reach, and then add arms. These are pretty, these are not easy exercises for the patients. It requires effort from them. They are intensive. Okay. See, if the patient is having, I just want to check, if the patient is having difficulty, if the patient cannot do, you don't have to tell them to take such a big step. Whatever they can do basically. If they can just take a small step and just they're doing only these arms, that's fine. You will begin and start with whatever they have. Then you will gradually progress with them. Okay, then this is one more. So this is side to side. So you stand, everybody stands with feet apart and turn fully to your back. Now you have to face your back with your hands stretched and come back. Again, go back, stretch, and then come back. So these are some of their maximum like daily exercises, but then they have a big protocol. It's an hour long, so they do hierarchy exercises, they do other functional exercises, and then they also get to do the homework. So this is basically the overview of what LSVT big is to give you guys an idea. And for this one, like you take your, they always say that you take the medication and then do exercises for the full success. This was the research that they did on LSVT big, and they had about 60 patients, and they told them to do the big protocol on the very left side. In the middle is their walk, and then this one is home exercises. This one was the Nordic walking, which they practice more in Germany. And then this one on the right side is more home exercises. So now here you can see that patient, this is the group with LSVT big, and this is the UPDRS score. Now, if you remember, what did I say? That UPDRS score has to be, if it goes lower, it is better. So here you can see that the UPDRS score went lower with LSVT big. That means they are improving. And these are the different studies and research that has been done on it. And they have found that the patient also had improved trunk rotation, patient stride length of gait, speed increase. The reaction time the patient takes to react to situations was lesser. UPDRS motor score went down. Balance improvement, coordination improvement, and also areas were improved. And also dual tasking, while so they could walk and talk, they could walk and do some other exercise, some other activity with it. So dual tasking also improved. So they found that there was a difference, not a difference, but there was an improvement in other activities also. This was one patient which they told him to write down things. He wrote down, and then after the treatment of 1 month, look at his writing. It's getting better. It's getting a little bigger. So it does go to different other situations, transfer to different situations as well. Okay, this was about LSVT big. There are many other techniques that have come up for Parkinson's disease, and I will be talking about some of them, like boxing therapy and walking. You could, be in touch with Dr. Himanshu. He's probably going to let you know and about my upcoming webinars. So we could talk about other therapies as well. Yeah, so these are the various famous personalities. You might already know about them. These are the famous personalities who have had Parkinson's already, and some are players, some are actors. Out of them, I like this quote the most: the only limitation one has are the ones they place on themselves. That was from Muhammad Ali. Thank you so much, and I'll be happy to take any questions. You can note down my email and phone number if you have any questions. Yes. Okay. Dr. Himanshu, what's the question? Or you want me to go to the chat and see? Okay. Okay, I opened the chat. Okay. Okay. I think now they know. Yeah. Yes, I can hear you, Dr. Himanshu. Yes. Yeah. Yeah, I know it's hard to go back. Or they can just unmute themselves. Dr. Himanshu, if you can, if they have anything, please unmute them. That will be easier. Oh, okay.